So, compliance, an indicator of expandability. Do your lungs have the ability to expand? Low compliance requires greater force. High compliance requires less force. Factors that affect compliance: connective tissue structure of the lungs, level of surfactant production. Okay? And then mobility of the thoracic cage. And that goes back to what I was just saying. You guys think I was just telling you that story about being in the sand because I thought it was a nifty story? Think about it. If you cannot expand your thoracic cavity, can you decrease the pressure to bring in air? No, you cannot. Now let's say that one more time. If you cannot expand your thoracic cavity, which reduces pressure, so air goes from a greater to a lesser, can you breathe? No. Okay? How about this? Someone you haven't seen in a long time gives you a gigantic hug and you're like, you're squeezing me too tight, can't breathe. Well, that's no surprise. Right? Yeah. So, what? Pressure changes during inhalation and exhalation can be measured inside and outside the lungs. Normal atmospheric pressure is 760 millimeters of mercury. 760, and yes, you do need to know that fantastic number. 760 millimeters of mercury, one atom. One atmosphere, not atom, like the atom, or the little boy atom. Atmosphere. Okay, one atmosphere. So, okay. So, intrapulmonary pressure, within, okay, also called intra-alveolar, within the alveolar pressure, is relative to atmospheric pressure. It's relative to that. Breathing in, breathing out. We're always exchanging air. That means that we're always going to equalize with atmospheric pressure. In relaxed breathing, the difference between the atmospheric pressure and intrapulmonary pressure is small. About -1 millimeter of mercury, inhalation, or +1, exhalation. It doesn't make sense? Okay, that's okay. So let's stick to this slide for a second. Okay, let's think about this. This is Louisa. This is Louisa on mathematics. Oh, we love you so much, Louisa. You're such a good sport. So, think about this. If I pulled down, the lungs inflate, right? What happened to the size of the jar? Did it increase or decrease when I pulled down? It increased. So if the volume increases, the pressure decreases. So where do we go when we're talking about pressure gradients? From a greater to a lesser. So let's say that right now we're equalized with 760, okay? And we decrease the pressure. Where did the air just go? In. Because this became less by 1.
So that's in.
There's the 1. Okay? Now let's increase the pressure. +1, where did it go? Out. Remember, the greater the volume, the less the pressure it's going to go in. The lesser the volume, the greater the pressure it's going to go out. Always equalizing with atmospheric pressure. Go ahead.
So, if you're already equalized, and then, never mind.
You got it? She's like, I'm already equalized. I got it. I know what you're talking about. So the numbers aren't scary. let's just do this, 760 relative number, okay? All of a sudden we go to 759 in the lungs. Where's the air going to go? In, from 760 to 759. Then we increase the pressure. As we increase, we equalize with atmospheric pressure. Then we go to plus 1, 761. Where did the air go? Out. Because if you're at 761, you need to go to 760. Right? Always equalizing with atmospheric pressure. Always equalizing with atmospheric pressure. So maximum intrapulmonary pressure, maximum straining, a dangerous activity, can increase from negative 30 millimeters to plus 100. Okay? And it says maximum strain, a dangerous exercise. So too much is what it's saying. Now we have a few things in place that prevent that from occurring. The thoracic cavity itself, the serous membrane that covers the lungs prevents overinflation. The thoracic cavity prevents overinflation. But let's think about this. When was the last time anybody in here, just raise your hand, I'll use you as an example, not a bad example, don't worry. When was the last time someone in here went hiking or on a long, super long walk but hadn't been on one in a long time? Anyone? You? Okay. So the next day or maybe 2 days afterwards, did your chest hurt?
Did my chest hurt?
Yeah. Did it feel uncomfortable, kind of like a pushing, like someone was pushing on your chest? Think about what I just said. You hadn't been on one in a long time. You went out and you did this. Maybe you tried to run or you hiked vigorously or something. The next day you're like, oh man. Your intercostal muscles and your diaphragm had to work harder to bring in more air to compensate for the strenuous exercise you hadn't done in a while. It's not a bad thing. It's normal. What they're saying is way above this. They're saying so far above this that you cause damage, tearing. So it's no surprise that people that haven't run for a long time, and they're like, I'm going to go run 5 miles, and they go run 5 miles, they're in pain for a week and a half afterwards. Because what did they do? They stretched their lungs and all the membranes to compensate for the amount of air they needed instead of doing it right. Now, there's 2 reasons why we say this. The first one is, if you're trying to exercise because you feel like you're overweight, don't start by couch run. That doesn't work. How about couch and a medium walk for about a mile and then stop? I know you feel good, but afterwards you're going to thank me. You're going to be like, thanks, Phil. Pal. Because first off, it's not about the amount of weight you have. It's the amount of exertion your body has to do or overcome or put forward. Okay? And that's what they're talking about here, is increasing it so much that it's devastating to you. It tears membranes. It causes problems. So it's really bad for you. In small amounts, it's okay. A couple days later, you were fine, right? Yeah, for the most part. Don't tell me it was a week. Was it a week?
No, it's fine.
Okay. I was like, you were running. You're not supposed to run. Yeah. Okay. Intrapleural, we're talking about the pleural cavity. Okay, pressure in space between parietal and visceral pleura averages -4. It's always a negative. Always a negative. Let me say that one more time. Intrapleural pressure is always a negative. Always. If it is a positive, you will collapse a lung. Okay? Maximum, -18, remains below atmospheric pressure throughout respiratory cycle. Okay, it's always a negative. Now that negative pressure is just like this. You see your hand? Pull. Don't worry, I won't let go. Pull, pull, pull. It's doing this all the time. It's always creating a negative pressure. And what that's doing is it's keeping your lungs out. If it becomes positive, push. I didn't see you. Pull, push, push, push. What happened to her? She slid backwards, right? Pulling pulls it out. Pushing. So if you become positive, you push your lungs in. Okay, the four most common methods of reporting respiratory gases. Don't worry about it. Okay, put a star by it. It says Phil said don't worry about it. We're going to actually hold on to just millimeters of mercury. That's the one we've been working with. We used it in blood pressure, so we'll use it here. Do not panic. Okay? Respiratory cycle. Well, changes in intrapleural pressure operate the respiratory pump, which aids in venous return. What? Huh. So I guess the only way that we could get lymph to go back would be skeletal muscle squeezing. Not smooth muscle. Well, that sounds dangerously familiar. Gosh darn smooth muscle. Gets you every time. Oh, back up. So, tidal volume, the amount of air moved in and out of the lung in a single respiratory cycle. In and out of the lung in a single respiratory cycle. Now, injury to the chest wall, pneumothorax, allows air into the pleural cavity, which makes it positive, not negative. Okay? Now, as we take a closer look at this, we have the right pleural cavity, the left pleural cavity, intrapulmonary pressure, that's within the lungs, alveolar pressure, okay, intrapleural pressure, and basically what they're saying is, notice down here, tidal volume, over 4 seconds, the amount that goes in and out. In and out. Okay? Now, the changes in pressure, notice the inhalation and exhalation. Now, over 4 seconds, so, wow. So how many times a minute do you think you breathe? 12.
Okay.
12 to 20. 12 to, yeah, exactly, 12 to 20 breaths per minute. But here's the downside. Louisa, hold still, I'm going to count your breaths, okay? Now she's holding her breath. So don't ever tell your patient that you're counting their breaths. Yes.
Is it different in children?
Yeah, oh yeah. Yeah, children will really hold their breath. Okay, I'm gonna check your respirations. Here we go. Oh, the number? Yeah, it's higher. Yeah, it's higher. I'm sorry, I didn't understand what you were saying. Yeah, children will really hold their breath. If you say I'm counting breaths, they'll be like, okay. Yeah, children, woo! Yeah, adults will do it too, but they do it kind of subconsciously. You look at them and they're like, okay? And gentlemen, when you're doing this, look at their stomach, okay? Because staring at the other body parts probably gets you whacked. Okay? Yeah, stare at their stomach. Just stare across their stomach right here and you'll be fine because most people breathe between their ribs and their stomach, so you see the rise and fall. Do not stare at their chest because that will, and you'll be lying on the floor. Okay? Or it'll get you a date, one of the two. Okay? So respiratory muscles. Well, diaphragm and intercostal muscles. Diaphragm and intercostal muscles. They're also known as accessory muscles. But they also, that intrapleural pressure is the pressure that helps return venous blood supply. Now, I've already talked about this. Squeezing of skeletal muscle and respiratory pressure returns the venous blood to the heart. That's nothing new. Mechanics of breathing. Well, inhalation's always active. Exhalation can be active or passive, so let's test this. And you know what? We will have this lab, but it won't be today. It'll be fun. I'm just going to give you a warning. If you smoke, just stop Wednesday night. Because Thursday morning, yeah. We don't want you wheezing for the rest of the day. Because that will occur. But I'll have the spirometer set up for us, and we'll come in. I'll go over the spirometers and tidal volume, and then we'll do the lab. Because there wasn't a lab for Thursday. So we'll put this lab on Thursday. That'll be more conducive to our learning. Okay? So what you guys will have to do is you'll actually have to take a breath. Just at regular breathing, not inhaling, and just and blow into it and watch it rise. Then what you'll do is go and then blow into it, and then you'll do this. And then once you reach that point where you passively let the air out, you'll forcibly let it out. And get all that air out as much as you possibly can. Okay? And you guys will battle with each other. You really will, like who has the biggest lungs. I personally think that it means something else, who has the most hot air, but that's okay. We'll do the lab. You guys will enjoy it. But yeah, if you smoke, just stop for the night before, because seriously, you're going to have some wheeze factor going on. But what they're talking about is inhalation, always, always, always active. But just exhalation, the first part is actually passive. Any more beyond that point is active. Because then you actually have to use stomach muscles to do it. So I want everybody to do this with me, okay? So everybody taking a deep breath. And then let it out to where it's just normal stop, okay? And now push beyond that. Okay, your stomach, your obliques, everything's going, okay? Yeah, so it's pushing all that air out. It is active at that point. A couple of you are like, lightheaded. Okay, muscles used in inhalation, diaphragm, external intercostal muscles, accessory muscles assisting in elevating the ribs. Well, sternocleidomastoid, fantastic. Serratus anterior, okay. Pectoralis minor, okay. Now, sternocleidomastoid, where's that at? Yeah, sternum, clavicle, and mastoid process. What? That's right. They name the muscles after either their insertion or their origin, or the bones that they're attached to. Go figure. Okay, so there's respiratory muscles, giving you a really good idea of how we breathe in. The pectoralis minor muscles right here, okay, definitely pulling down. Okay, lifting the rib cage up. Yeah. So does your rib cage rise when you breathe in? Yep, certainly does. Okay, and this is the first image that we were looking at, the mechanics of breathing. Up and out, down on the diaphragm, air goes in. And there you go. Up and out, down on the diaphragm, air goes in. Didn't we increase the volume? So if the volume increases, the pressure decreases. If the pressure decreases, don't we go from a greater to a lesser by 1? I know. Muscles used in exhalation, well, internal intercostal and transversus thoracic muscles. Depress the ribs. Abdominal muscles compress abdomen and force diaphragm up. And that's not passive. That's actually aggressive. If you just let go, nothing really happens. It's when you force out that something occurs. Okay, so there you go. Notice the rectus abdominis moving downward. Okay, modes of breathing. Respiratory movements are classified by patterns of muscle activity. Quiet breathing and forced breathing. These are terms that we will use in the lab. Quiet and forced. That's why I said wheezing. Unbelievably, we use that in a clinical setting. Is a patient wheezing? Are they gurgling? That's bad, by the way, if they're gurgling. Crackling, rails. These are all breath sounds. Okay? And interestingly enough, If you're an EMT, paramedic, or EMT IV, you listen for lung sounds and you actually make notes on it. But when you go into the hospital, they won't let you do that. You have to be a nurse or a doctor to do it. Odd, but okay. They'll trust you outside of the hospital, but once you're in the hospital, they won't let you do it. So just keep that in mind that if you're outside of the hospital, pre-hospital care, you're going to learn all this stuff. If you make it into the hospital, it won't happen until you become a respiratory therapist or a nurse or a doctor. Okay? So breathing, quiet breathing, yupina. Just think of it this way. You are normal. Honestly, you means you are normal. It means normal. Normal breathing. You are normal. Yupina. Okay? Involves active inhalation and passive exhalation. Costal breathing or shallow breathing is dominated by the rib cage. So kids sometimes will do that. And all you see is the rib cage moving. And then you'll see stomach moving. Deep breathing. Okay? The kids stomach breathe, and it looks like they have pumpkin, no pumpkin, pumpkin, no pumpkin, pumpkin, no pumpkin. It's craziness. Okay? Or in the case of my wife, pregnant, 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 pregnant. Okay, elastic rebound. When inhalation muscles relax, elastic components of muscles and lungs recoil, returning the lungs and alveoli to their original position, which is good. Okay, any type of damage to this recoil causes problems with breathing. Forced breathing, okay, involves active inhalation and active exhalation, assisted by accessory muscles, more so. Okay, so respiratory rates and volumes, and this is what we need for the lab. We need this. So respiratory system adapts to changing oxygen demands by varying the number of breaths per minute, respiratory rate, the volume of air moved per breath, tidal volume. How much did you move? Tidal volume, how much did you move? So respiratory minute volume, the amount of air moved per minute. So is calculated by respiratory rate times tidal volume, which means now you have to have a number for tidal volume. So let's back up. Okay, respiratory system adapts to changing oxygen demands by varying the number of breaths per minute. How many breaths per minute did you breathe? Now I said normal is what? 12 to 20. Normal is 12 to 20. If you go above that 20 mark, then it changes how much volume is being exchanged. But like blood, if your heart pumps so fast, is there time for filling? No. You have to think the same way. Okay, so is calculated by respiratory rate times volume, tidal volume, so now we have to have a number for tidal volume. Alveolar ventilations, only a part of the respiratory minute volume reaches alveolar exchange. Volume of air remaining in the conducting passages is called dead space. So everybody breathe out. There's still air left in your conducting system. Let me say that one more time. When you breathe out, you didn't get rid of all of it. That means there's still air left in the conducting space. That air is called anatomic dead space. Nothing's really happening. There's air there, but it's not doing anything. It's just filling space. So it's no surprise that when you do this, you're actually pushing more from your lungs. So you're moving what would have just been resting in dead space out and adding a little bit more to it. But your lungs are never empty. Never. Which means dead space is never empty. Okay, alveolar ventilations and the amount of air reaching, or is the amount of air reaching the alveoli each minute, calculated as tidal volume minus anatomic dead space times respiratory rate. We haven't gotten to the numbers yet. Louise is like, I want numbers. I want to start to calculate. She's a wizard when it comes to math. She's like, give me the math. Okay, so tidal volume minus tidal volume, the total volume, minus the dead space, okay, times respiratory rate is alveolar ventilation. Alveolar gas content, alveoli contains less O2 and more CO2 than atmospheric air. Well, atmospheric air is going to have an amazing amount of O2, okay, and very little CO2. So, because air mixes with exhaled air, we're always going to have an exchange. Now, we're going to talk about this thing called partial pressure. Partial pressure. Let me say it one more time. Partial pressure. Well, partial means that you only have one part of something. That means you have to have multiple other parts to make complete pressure. So, relationship among VT, VE, and VA, that sounds like a hospital, okay? So, determined by respiratory rate and tidal volumes. For a given respiratory rate, increasing tidal volumes increases alveolar ventilation. For a given tidal volume, increasing respiratory rates increases alveolar ventilations. Okay? So, as confusing as this sounds, all it's saying is that the more you take in, the bigger your numbers. Okay? That's all it's saying. The more you take in, the bigger your numbers, the more tidal volume you have. And then at what rate do you exchange that tidal volume per minute? How much of that volume do you move per minute? Okay, that's all this is saying. All the fancy numbers and the terminology aside, let me say it one more time so you can write it down. All it's saying is how much volume did you take in? How much volume did you take in? How much volume went out? Okay, over a period of time, which is your respiratory rate. So how much volume total did you move per 1 minute of breathing? So, one ventilation in and out is a set volume. Now, how many of those did you have over 1 minute? Well, if you had 12, and that volume was a certain amount, it would be 12 times that volume. It's very, very simple math, nothing crazy going on. So all they're saying is how much volume do you have, how many times per minute are you moving that volume, and that's your number. So they are going to talk about leftovers, though. This is always good. I like to use the word leftovers because we understand leftovers as opposed to end respiratory volume. Okay? So it says respiratory performance and volume relationships. Total lung volume is divided into a series of volumes and capacities useful for diagnosing problems. Well, we're not going to be doing a lot of diagnosing, but we are going to actually talk a little bit about this. It says 4 pulmonary volumes. Resting tidal volume. Expiratory reserve volume. Residual volume and inspiratory reserve volume. Okay, so let's start with expiratory reserve volume. Everybody breathe out. Now push even harder. That was the leftover. That was your reserve volume. Right? Normal volume is just in and out. Whatever's left over. Let's go the other way so it's a little easier on you. Everybody breathe in. Now breathe in more. Keep going. Keep going. Keep going. Come on. Keep going. Fill the lungs up. Keep going. Inspiratory reserve volume. So when you breathe in a little bit, that's normal. Breathe in more. Now you have more. See how that works? Same with breathing out. Keep breathing out. You've just gotten rid of your extra. Resting tidal volume in a normal respiratory cycle. Expiratory reserve volume after a normal exhalation. Residual volume after maximal exhalation, minimal volume. Okay? And then inspiratory reserve volume after a normal inspiration. Do we use these? not at rest. Let me say that one more time. We do not use these at rest. Now, we do use these as a test to test elasticity, okay, recoil. We use them as tests in the hospital, but for the most part, these aren't going to get pushed to their limits unless you're doing what? Exercising. I just heard someone say that. Yeah. So at rest, are we doing this at rest? No. That'd be weird. You'd scare people. Or calculated respiratory capacities. Inspiratory capacity, functional residual capacity, and vital capacity. Well, what do they mean? Well, they're explained. They're pretty actually straightforward. Vital capacity, expiratory reserve volume plus tidal volume plus inspiratory reserve volume. That's pretty much total capacity, right? Because what's it saying? Well, tidal volume, normal. Expiratory, pushing harder. Inspiratory, drawing in harder. Yeah, that's like everything. That's the full table. That's the full meal deal right there. All right? Functional, expiratory reserve volume plus residual volume. And then inspiratory capacity, tidal volume plus inspiratory reserve volume. Are we going to be doing a bunch of these calculations? No. No. We will need to know about the laws, and we already have one law, which is what? Boyle's. So 4 calculated, total lung capacity, vital capacity plus residual. So whatever was left over plus vital, that's it. Now, pulmonary function tests measure the rate and volumes of air movements. This is what we will do on Thursday. We'll measure the rate and volume of air that you're moving, which means you will count respirations with your partner. Okay? We will do tidal volumes. How much volume are you exchanging? Okay? So really what this is doing is just giving you insight to the tests. Is this normal? No, not really. Because as a nurse or an EMT or a tech or anything like that, all you're doing is how many breaths per minute. Are we going to do that in the classroom? Yes, we are. You will count how many breaths per minute. Okay? I mean, unless you guys absolutely want me to have you memorize every little aspect of this. No? Okay. Please be advised that you do need to understand some of the not the calculations, but you need to understand the definitions. Okay? What are the definitions? Which they're spelled out for you right there. Okay? They're literally spelled out for you. The definitions are very straightforward. Okay, this just tells you where the volumes are. Now, gas exchange occurs between blood and alveolar air across the respiratory membrane, which we'll get to tomorrow. Okay, partial pressure of gases, partial pressure.